Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article Engage, Evaluation of a Streamlined Oncologist-led BRCA Mutation Testing and Counseling Model for Patients with Ovarian Cancer by Nicoletta Colombo et al. My name is Dr. Nadine Tung, and I am an Associate Professor of Medicine at Harvard Medical School and the Director of the Cancer Genetics and Prevention Program and Breast Medical Oncology at the Beth Israel Deaconess Medical Center in Boston, Massachusetts. Several national guidelines now recommend germline genetic testing for mutations in the genes BRCA1 and BRCA2, hereafter referred to as BRCA testing, for all women with epithelial ovarian cancer. Approximately 15% will be found to have a mutation. Identifying a mutation can inform treatment decisions regarding the benefit of using an inhibitor of the enzyme poly-ADP ribose polymerase, known as a PARP inhibitor. In addition, identifying other family members with the mutation can trigger appropriate cancer surveillance and prevention strategies. Yet underutilization of BRCA testing among ovarian cancer patients remains a significant problem, with recent studies demonstrating that as few as 10% undergo testing. Several barriers to testing have been identified, including an insufficient number of genetic counselors. Even when available, studies have shown that for some cancer patients, the need to meet yet another provider at the time of diagnosis is sufficiently burdensome to preclude testing. Whitworth and colleagues reported in the Journal of Oncology Practice that after one large insurance payer instituted a policy mandating a consultation with a genetic counselor prior to genetic testing, 30% of ovarian cancer patients referred for BRCA testing canceled their appointment, compared with only 6% prior to this requirement. In addition, the time to receive genetic test results increased from 14 to 28 days with the mandate to see a genetic counselor. In order to facilitate more widespread genetic testing, the current study by Colombo and colleagues assessed whether a streamlined, oncologist-led approach to BRCA testing would be feasible and acceptable to oncologists and patients with ovarian cancer. The primary endpoints were 1. Turnaround time, defined as the time from consent to receipt of results by the patient, and 2. Satisfaction among oncologists, genetic counselors, and patients measured by various standardized questionnaires. The current Engage study built on a successful pilot conducted at the Royal Marsden Hospital in London, using an oncologist-based strategy for conducting BRCA testing in ovarian cancer patients. That study demonstrated a 4-fold decrease in the time to receive test results, which had previously been, on average, 20 weeks using a conventional genetic counselor-led process. The Engage study was a prospective observational study that enrolled 700 patients with ovarian, tubal, or primary peritoneal cancer at 26 sites in the United States, Italy, and Spain between April 2015 and September 2016. Oncologists and oncology nurses received training about the clinical implications of BRCA mutations and genetic counseling. Patients received pre-test counseling by an oncologist or oncology nurse, and were provided with written material. Prior to genetic testing, patients were offered an appointment with a genetic counselor if desired. Results were disclosed either by a genetic counselor or an oncologist, which was decided by individual sites. Mutation carriers were advised to set up an appointment with a genetic counselor. Patient, oncologist, and genetic counselor satisfaction with the testing process was assessed through established questionnaire tools. Turnaround time was measured from the time a patient received pretest counseling to provision of results to the patient. If a patient was notified of results remotely but discussed the implications of the testing in person, turnaround time was calculated from pretest counseling to the in-person post-test counseling. What were the results? Consistent with prior studies, nearly 14% of patients were found to have a BRCA1 or BRCA2 mutation, and only 54% of mutation carriers had a family history of breast or ovarian cancer. In Europe, all the pretest counseling was performed by oncologists, while in the United States, 60% was conducted by oncology nurses. Overall, the median turnaround time was 9 weeks, though there was significant variation among countries. In the United States, the average turnaround time was 4 weeks, in contrast to 20 weeks in Italy. Two factors contributed to the shorter turnaround time in the United States than in either European country. First, turnaround time was longer with use of a central lab rather than a hospital-based or commercial lab, which is the routine practice in the United States. Second, in the United States, negative, meaning normal results, are more often delivered by phone, thus decreasing turnaround time. Oncologists and patients appeared satisfied with the process. 84% of the 52 oncologists who completed satisfaction questionnaires thought this model worked well. Oncology providers spent a median of 20 minutes delivering pretest counseling, though the range was from 2 to 115 minutes. Patient satisfaction was also high. More than 99% of patients were satisfied with both pretest and post-test counseling. Consent for genetic testing was usually obtained at the time of initial counseling. Only 2 patients requested an appointment with a genetic counselor prior to the test being sent. Satisfaction was lower among the 18 genetic counselors who completed questionnaires. The most common concern involved patient knowledge prior to testing. Half of the genetic counselors did welcome the oncology team performing the pretest counseling and felt the patients received accurate information. This study addresses the extremely important topic of delivery models for genetic testing. With an increasing number of oncology patients requiring genetic testing, genetic counselor shortage is a significant problem. Genetic testing for oncology patients usually requires that results be obtained quicker than for individuals without cancer, since results may impact cancer treatment decisions. Thus, many are now exploring the optimal way to conduct so-called medical genetic testing for oncology patients, in contrast to predictive genetic testing for those without cancer, for whom results are used to predict future cancer risk. Does this model seem feasible? Since the innovative aspect of the study is to have oncologists and oncology nurses conduct the pretest information sessions, a teach-the-teacher approach, it would be helpful to more fully understand how the oncology team members were trained. Educational slides were provided to the oncology team and are provided in the supplementary material. They are comprehensive. Was there any in-person training of clinicians, or was all training self-directed using the extensive educational material? Also, while oncologists were generally satisfied with this BRCA testing pathway, most of the counseling in the United States was conducted by nurses who were not queried about their satisfaction with the process. In addition, it is not clear how representative the oncologist responses are. We are told that 52 completed questionnaires, but not how many participated in the study. It is perhaps not unexpected that genetic counselors were less satisfied with the streamlined testing pathway. Their concern was that patients did not have adequate knowledge. The median time for pretest counseling in this study ranged from 2 to 115 minutes. Given the information needed to provide informed consent, 2 minutes is indeed concerning. However, patients did receive written material in addition to counseling, and it is noteworthy that patient satisfaction with the counseling process was high. This study was not randomized, and so we're not able to compare patients' knowledge using a conventional genetic counselor-based process with the oncology-led pathway employed in the ENGAGE study. However, since 85% of ovarian cancer patients will not be found to have a BRCA mutation, it's important to balance the benefit of possible increased patient knowledge with the need to conduct genetic testing on an increasing number of oncology patients. 18 genetic counselors is a small sample size, and since again, we are not told how many genetic counselors who participated in the study actually completed questionnaires, it is not clear how representative these genetic counselor impressions are. Finally, while the study recommended a genetic counselor appointment for all mutation carriers, we are not told how many complied. This is important since oncologists may justifiably focus primarily on the impact of results on treatment, whereas genetic counselors are trained to emphasize the importance of cascade testing for relatives. The number of individuals eligible for germline genetic testing is constantly increasing. This study confirms the need for universal BRCA testing for all ovarian cancer patients, since 46% had no family history of breast or ovarian cancer. Further, NCCN now recommends BRCA testing for HER2-negative patients with metastatic breast cancer who would be appropriate for treatment with a PARP inhibitor, following the positive results of the Olympiad and now EMBRCA trials. As the pool of oncology patients requiring genetic testing increases, new delivery models for testing are needed. A one-size-fits-all model for every community-based or academic hospital is unlikely. But the approach evaluated in the ENGAGE study is an innovative and sensible option that utilizes the oncology team to provide the initial counseling and testing. Since most patients will not have a mutation, this approach allows the valuable but limited resource of genetic experts to be reserved for those who need their counseling most, those who have a mutation or a genetic variant of uncertain or unknown significance. However, it is essential to ensure that patients still receive sufficient information before testing to enable them informed consent. Patients must be educated regarding the potential implications of genetic testing, even if extensive pretest counseling is not conducted. ASCO has outlined the essential components of informed consent and pretest education for those undergoing genetic testing in their 2015 ASCO guidelines by Robson et al., published in the Journal of Clinical Oncology. Employing the mainstream medical genetic testing for our oncology patients and the need for informed consent will become even more challenging with use of multi-gene panels, so commonly ordered these days. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.